Welcome to Life in Sirens, Behind and on the Scene, a podcast by first responders. We're your hosts, Sophie,
Jamie,
and Aubrey.
The content provided in this podcast is for informational and educational purposes only and should not be considered medical advice. The views and opinions expressed by the hosts and guests are their own and do not necessarily reflect the official policies or positions of any medical institutions, emergency medical services, or healthcare organizations. Patient privacy is a top priority, and all discussions involving real-world emergency situations are de-identified and altered to ensure confidentiality. Always consult with a qualified healthcare professional or your local EMS protocols before making any decisions regarding patient care or medical practices. Listener discretion is advised, as some topics may include discussions of real-world emergency situations. Welcome to another episode of Life in Sirens. Today it's just going to be me, James. It's officially winter time. It gets dark so early, and we just run out of time in the day. So me and the girls have had a hard time scheduling a time to record, but we wanted to get one out for you today. So this is going to be a little bit of a short one, but we're going to go over when to say when. And so there's a moment that every provider knows. You're standing at the foot of the stretcher. You've got a sick patient, but they're not crashing. Their vitals are okay-ish. Mental status is off, but not gone. And you can feel it. Like you feel it in your gut. And the question isn't what you could do, but it's when. So do you RSI now, or do you wait? Do you cardiovert, or do you try one more med? Do you divert? Do you upgrade? Do you call for help? Do you ride it out? Like, what do you do? And that moment, that hesitation, that internal debate, that's what this episode's going to be about. Because knowing how to do big interventions is one thing, but knowing when to say when is an entirely different skill. And no one teaches that very well. And the hard truth is that the reason nobody teaches it really well is because a lot of times it comes with experience. So you can't shortcut pattern recognition. Now, some people are better at it than others, but it is something that comes with time. And you can't download intuition. Now, a lot of EMS providers have a damn good intuition. It's something about our personalities that we're drawn to this field when you're really intuitive, and it's pretty helpful. But other than that, like, you have to earn it. You earn it call by call, mistake by mistake, success by success. And we don't talk about it enough. And so experience, though, it doesn't mean recklessness. And caution doesn't mean weakness. The goal is to figure out how to not be the provider who waits too long, and how to also not be the provider who intervenes just out of fear. And so the real skill is going to live somewhere in the middle. So today, what we're going to talk about is, one, why this decision feels so hard, what experienced providers are actually keying in on, and practical anchors that new providers can use to decide when to act. And to be perfectly honest, I would not necessarily consider myself new. I'm like 10 years in, but I still use these anchors all the time because it helps me organize my brain. So why is the when harder than the what? So protocols tell you what you're allowed to do. It tells you for what pathologies you use certain interventions for, but it rarely tells you when it's time. Like, I remember when I was going through medical school, I really just wanted a list. I wanted a step-by-step instructional list of this person looks like this, you do this. And we just don't have that for every situation. And I realized later on that it's much more valuable that we don't. But figuring your way and like navigating your way through that is tough. And so most patients, they live in gray areas because they don't read our protocols, and they're jerks, and they don't present the way we want them to, which is not super nice. They live in compensated shock. They live in that zone of protecting their airway until they're not. And they're tachycardic, but they're mentating. They're hypoxic, but they're talking. They're stable for now. And here's what makes it worse, is that high acuity patients can often look calm right before they fall apart, especially if they're chronic. And so your brain has to juggle fear of being too aggressive, fear of waiting too long, fear of judgment, fear of causing harm, fear of missing the window entirely. And that tension, it's not incompetence, it's clinical maturity developing. So that tension is a good thing. That feeling in your gut where you're like, oh gosh, when do I do it? That means that, one, you care, and that you're trying to learn that intuition, because some providers never learn that line. They either wait until the patient decompensates so much that they're no longer in a gray area. Now it is black and white. And that is a strategy, just not a super great one. So let's talk about the experience factor. What does experience actually give you? Because it's not magic. It doesn't just mean that you've sat on a truck for 20 years and now all of a sudden you're just like super good at this job. But it does give you a memory of patients who looked fine until they weren't. We've all had a patient that was compensating really well, that we thought was going to maintain all the way to the ED, and then all of a sudden things started going horribly, horribly wrong. It gives you a sense of trajectory, not just little snapshots. So you can start to piece together the longevity of your patient. You can start to piece together where they're coming from, where they're going to end up, what that middle section is going to look like. You can really start to put together all of these pathologies in different patient populations because you've seen a lot more of them. And you also get a shorter tolerance for false reassurance. What I mean by false reassurance is like, okay, we've all had that patient that they're working really hard, they're tripoding, they're diaphoretic. You're like, oh, this is bad. But then you ask them how long this has been happening, and they answer you in like a full and complete sentence. Now, it's still a little labored and it's still with effort, but you're like, oh, full sentences are good, right? This patient is not in one breathless word, and full sentences are good, and so that means we're fine. And those are what I call false reassurances, because that just may mean that this patient's done this a lot of time and they're less fearful of hypoxia, and so they're willing to talk to you. It doesn't necessarily mean that they're not doing poorly. So experienced providers don't just ask, what do the vital signs say right now? They ask, where is the patient going in the next 10 minutes? So we find our right now, and then we kind of try to paint ourselves a picture of what's there. What are they going to look like going forward? Is this just going to like fix itself? Can I do minimal interventions for this to be fixed? What are we looking at? And so you don't want to wait for your blood pressure to tank. You don't want to wait for your GCS to drop to 8, which is arguably a horrible indicator of if you should take somebody's airway. Please use other assessment skills. And on that topic, you don't want to wait for their airway to be lost. You don't want to have to intervene because you've waited so long that now you have no choice. Experienced providers try to intervene when you see the cliff approaching, not when you're falling off of it. But if you're newer, you don't necessarily have that lived reference yet. You need anchors. And we're going to talk about those. Where are some good step-off points? Some places that you can find yourself and say, oh, okay, this is a point where I need to start making decisions. So our first anchor is going to be trend. Trend greater than number, right? So one bad vital sign can be noise. It can just be a fluke. It can be less than a concerning issue. But a trend is going to be a warning. So you want to ask yourself, not did they have one blood pressure that was hypotensive on our monitors that are made poorly for pre-hospital medicine, but is the blood pressure drifting down despite intervention? So are we still trending down? Or are we trending up despite intervention? Is the heart rate climbing? Is the heart rate falling? Is our oxygen requirement escalating? So let's say we have a patient who's hypoxic, mildly. We're like 87, right? Not great, not terrible. They desat to 83 when they stand up to walk to the stretcher. We don't love that. Put them on 2 liters, they go up. We get them in the truck. About halfway through your transport, you recognize that they're back down to 87, but without any exertion. We're still on 2 liters. Nothing has changed. You crank them up to 4 liters. Their O2 comes up. It doesn't necessarily mean you have to intervene past that, but it is something to clock. Their condition is worsening because their oxygen requirement is escalating without any external catalyst, if that makes sense. And then is their mental status slowly deteriorating? So are you going from someone that's completely alert and oriented to someone that is no longer situationally aware? So if the patient's requiring more work from you or more work from themselves in order to stay the same, then that's not stability. You're on borrowed time. So a good rule of thumb is if you've corrected the obvious causes and the patient still needs escalating support, then it's time to act. If your corrections are no longer working, if you have to increase the support, then it's time to start thinking down the road of our next more serious intervention. So our anchor point number 2 is going to be work of compensation. So how hard are your patients working to stay alive is very important. Do they have an increased respiratory effort? Are they diaphoretic? Are they anxious or agitated? A good rule of thumb is anxiety and agitation is always hypoxia until proven otherwise. There are a couple patient populations where that is probably not the case, but if somebody is anxious or agitated, get a SAT, get an end tidal, figure out if hypoxia and perfusion is really your issue. Are they tachycardic without pain? Are they holding on to your stretcher side rails for dear life? Because the tighter a grip a patient has on your side rails, the more fearful they are that their condition's worsening. Watch that. Or have they been that way and now they're just silently exhausted? All of these are signs of pre-collapse. All of these are signs that your patient is moving into a decompensating phase. So a patient who is compensating and compensating well looks decently calm. But a patient who's barely compensating, so maybe we're not to the decompensated aspect yet, but we are like barely doing well, they're going to look really busy. They're going to look like they're putting in a lot of effort. So when you see increasing work of breathing, when your patient seems to be thinking really hard about what they need to do next, those are all things that is a great indication that the body is spending its last reserves. The body is pushing everything that it has left to try to keep them above that bell curve. And oftentimes that's going to be your win. When you see those things, that's going to be the win for your next intervention. Because you want to do it not necessarily before they need it, but before you don't have another option. There's this weird window in between the it's not necessary and I have no other choice. And you want to land in that window. So moving on to anchor number 3. Mental status change is a late sign. So this one is critical for new providers because we're always taught that like the symptomatic version of any pathology is altered mental status. And it is, and that is a good line to have. If somebody is altered, it's serious. But we don't necessarily have to wait for altered mental status. If you're already altered, then it's pretty late in a lot of pathologies, especially if you're altered in shock, hypoxia, sepsis, a head injury. Subtle changes are going to be much more important. Obviously, in altered mental status, you don't want to miss. But if you can pay attention to the subtlety that comes prior to that, it's going to help you be more prepared. So if somebody is just having slower responses, if they've lost situational awareness, if they're quiet instead of anxious, like maybe family reports that they've been really anxious for like an hour or so and now they're just chilling, probably not a great sign. If they're repeating questions, so if they're asking you, am I going to be okay? Am I going to be okay? Am I going to be okay? A lot of times that's an indicator that they're getting worse, that they're like kind of edging that way. And patients, especially respiratory patients, will say, I'm just really tired. And a tired patient, especially a tired respiratory patient, is tough. That is a sign that you need to be prepared for a lot of next steps. When these things happen, when these changes happen, and you can see somebody starting to like edge towards alteration, that's the brain conserving energy. So the brain is focusing on firing the signals that are necessary for survival, not necessarily taking in the environment around them. And so things are starting to turn. And this is a great point to start considering your next intervention. This is going to be that window between the not right now, I absolutely have to. This is that in-between window where you're getting prepared before you absolutely need it. So anchor number 4, if you are debating it, so if you and your partner are talking about it, if you're thinking about it, then prepare for it. So this is one of the best practical skills you can develop. So if you're asking, do I need to RSI this patient? Do I need to cardiovert this patient right now? Or are we okay to try some meds? Do I need pressors right now? Or will a fluid bolus suffice? The correct answer might be not yet, but I need to get everything ready. So it might be, we don't necessarily need to cardiovert right now because I think we're in that middle of that window, but I am going to put the pads on them. I'm going to try these meds, but we're going to put the pads on. We're going to be prepared for that. I'm going to make sure that I'm familiar with all of my electrical dosing and everything. Do I need to RSI them? Well, maybe not. Maybe not right now. Maybe BiPAP is still an option. Maybe you can throw that on there. Maybe CPAP's still an option. But know where your meds are. Calculate your patient dosing. Make sure you have all your intubation stuff set up. If you are prepared, then that next step, making the decision to that next step, is actually going to come much more naturally than you might think. Preparation in this regard is going to buy you some safety. And really, it's just going to buy you the feeling of safety. So you're going to feel like you're ready for whatever comes your way. Because when this moment comes, when it shows up, you're going to have time to decide or to act. You rarely have time to do both. And that gets messy. So anchor number 5, this is the no return zones. So there are certain patient presentations where waiting rarely helps. And so some patients don't have this window. Sometimes you can't find it because it's not there. And so some examples where you act now, you act quickly and you act aggressively is progressive hypoxia with fatigue, shock with narrowing pulse pressures, bradycardia with hypotension and altered mentation, sustained tachydysrhythmias with poor perfusion, sepsis with worsening mental status despite a fluid bolus, head injured patients losing protective reflexes. In these cases, hesitation and waiting and watching is going to cause worse physiology, more chaotic interventions, and fewer options later on. So for these presentations, big interventions done early and controlled are safer than desperate ones done later. And so these anchor points are going to help you recognize when your patients are already so far around that curve that now it's big and it's now, instead of kind of standing and waiting and seeing what we need to do next. So these are all some points that are going to help you decide when to intervene, right? But what about when not to intervene? Like when writing it out is the most appropriate action, because that's super important too. And sometimes the right move is to not act, right? So some examples of when this is happening is when your patient's improving with treatment. So let's say you get a respiratory distress, they're an asthmatic, they are a silent chest, they are air trapping. We're not really wheezing because we're not even moving enough air to wheeze. So you throw them on a neb, you give them IM epi, you get some Decadron in them, maybe you start mag, and then we wait and we watch and things get better and they start to improve. And now we can hear wheezing and they're less breathless and they are looking at you not like they're going to die, but like they want to say thank you. That is a great example of an improving patient. And so now you can pause at each step of those interventions and see if you're improving. And you may not need to escalate further than that. If your trends are stabilizing, so you had a patient that was initially hypoxic and they were becoming more and more hypoxic, you provide a intervention like a non-rebreather, and now they are trending up and they're no longer hypoxic and their mentation improves. Great, that may be enough for them right now. Their mental status is improving. You have time and access to definitive care. So maybe you're only 5 minutes from the ED. Maybe it's going to be within that patient's best interest to get to an ED, to get a chest x-ray, because maybe they need to go to IR, right? So understanding your transport time and what that looks like for your interventions is also important. The intervention risk outweighs the benefit right now. So it doesn't necessarily mean that they won't need a higher level intervention. So I think a great example is when you have a patient that's in respiratory distress. This has happened to me on multiple occasions. They're in respiratory distress. Let's say we're a COPD or with pneumonia, right? We've got a couple pathologies going on. Things are not going well. We have a 15-minute transport. We get them in the truck. We get some lines started. We get them on CPAP. They're tolerating it, right? We've improved, but we can't really get them to sat past like 88, but that's okay. We're hanging in there. We're doing all right. This patient may still end up getting intubated, but it doesn't mean that they need to be intubated right now. Because for me, that risk is going to be will far outweigh the benefit. Because right now, if I intubate them, that means that they may never come off a vent. And so maybe when we get to the ED, they wait for another hour and then they still get a tube. But it doesn't necessarily mean that they needed it when I had them. It may mean that we've progressed to that point where now it is the only option. But sometimes you waiting is the best course of action for your patient. So wisdom is knowing that you don't always have to act. Sometimes it's restraint with vigilance. And so you need to understand why you're waiting. Don't just wait out of fear. But if you're waiting with intent, sometimes that's the best choice. So the key difference there is that you're not ignoring your patient. You are actively reassessing. So make sure that you do an intervention, you reassess. Perform a second intervention, reassess. Aubrey always says like ABC 1, 2, 3. And it's because you intervene in airway, you move to breathing. You intervene in breathing, you move to circulation. You intervene in circulation, you go back to airway, right? You assess airway, breathing, circulation, and then 2, airway, breathing, circulation. And you continue to move in that circle until you can continue to address all of the issues your patient's seeing. The way that paints reassessment in my brain is so helpful because you have to keep reassessing everything that you're doing. Because if you just intervene and then you sit behind your patient and you type on the computer, you're going to miss so many things. Yeah. So that's really it. That's what I got for you guys. So some final thoughts is a few things that I want you to remember is that hesitation is not weak and acting early is not reckless. As long as you are assessing your patient correctly, you're following trends and you have a good handle on what pathology looks like that's going to have that window for you to be able to jump in, or if it is already so far down that curve that like you've got to do something big and you've got to do something right now, it's wise to be able to understand the difference in hesitating because you're fearful or hesitating because it's what the patient needs, and acting early because you're fearful or acting early because it's what the patient needs. Your goal is not perfection, nor should it be. Perfection is a relatively unattainable standard, and instead, make your goal intentional decision making. So learn your patient's pathologies, put those things in your memory bank when you see it in a patient presentation that's maybe unfamiliar for you. Remember those, keep those, and start making decisions intentionally. Start preparing prior to needing an intervention intentionally. And then every experienced provider that you admired, that you still admire, that is a mentor that you look up to, they stood exactly where you're standing. They were unsure, they were uncomfortable, and they second guessed everything they did. They left a call and they looked at their partner and they were like, well, that was terrible. And their partner had to reassure them that they were not the most trash medic in the world. This happens, and honestly, it should happen. It means that you're questioning yourself. It means that you're willing to grow and to learn. And so the difference between you now and them now is that they've had the time and the opportunity, and they've learned to recognize the moment when waiting stops being safe. And so they learn to follow the trajectory and to paint themselves a little roadmap into the future where they can kind of understand where their patient's headed. So the next time that you feel that tension, that feeling in your gut, that little voice that's like, do I do it now? Do I do it now? Just listen to it. Prepare early, watch your trend, respect a patient's compensation, either work with it or if it's failing, take over. And remember that sometimes the bravest and the best decision is acting before the patient forces your hand. And sometimes it's not acting at all. So that is all I have for you guys today. That is the when to say when. When sometimes you know the what, but you're not sure when exactly to use it. So I appreciate you guys listening to us. And next week, me and the girls will all be back. So see you later. This has been Life in Sirens, produced by 3 nerds trying to bring you content that you might actually care about.